Angel's nursing decodes. In this video, I am going to discuss about intrauterine growth retardation. So, you all know about this topic. Intrauterine growth retardation means during the pregnancy, the fetus won't get adequate body weight according to their gestational age. So, this growth retardation is known as intrauterine growth retardation. It's a common complication of pregnancy in developing countries and carries an increased risk of perinatal mortality and morbidity rates. And it is otherwise termed as small for gestational age or fetal growth restriction. Definition: it is said to be present in those babies whose birth weight is below the 10th percentile of the average for the gestational age. Normally, the weight of the babies will be between 10th percentile and 90th percentile of the growth chart. Then it is considered as normal weight. And if it is going below 10th percentile, then it is considered as underweight, and if it is going above 90th percentile, then it is termed as obese. So here the baby's weight is going below 10th percentile and hence it is termed as intrauterine growth retardation. Incidence in newborn, it would be between 3% and 7% of total population. And in Asian countries, it is about 75% of all affected newborns. And Africa, it's about 20%, and in America, it is 5%. And the neonatal perinatal database of India reported the incidence of Iugr to be 9.65% among hospital-born live birth infants. Next, moving on to types. The first is symmetrical and the second one is asymmetrical. So, in this picture you can see the first image is appropriate growth profile. That means the baby is having, not baby, fetus. Fetus is having normal growth according to their gestational age. And in second picture, it is shown that the head is having the same circumference as the abdominal circumference. That means the symmetrical growth is present throughout the body. Hence, it is known as symmetrical Iugr. And the third picture, it is mentioned that the head is large while comparing to the body. Hence, it is termed as asymmetrical Iugr. Next, moving on to types of Iugr. So, the symmetrical Iugr accounts about 33% of Iugr infants, and asymmetric Iugr, it's about 55% of Iugr, and the combined type is 12% Iugr. Next, we can see the difference between symmetrical and asymmetrical Iugr. So first, the incidence. Symmetrical Iugr is about 20%, but the asymmetrical type is about 80%. And the size, while comparing both, the symmetrical Iugr is uniformly small, while the asymmetrical type has the head larger while comparing the abdomen. Next, Ponderal Index. It's normal in symmetrical and low in asymmetrical. Next, head circumference is to abdominal circumference, and the fetal length is to abdominal circumference ratios is normal in symmetrical type and elevated in asymmetrical type. Then the total cell number, it's less in symmetrical type and it's normal in asymmetrical type. Then the cell size, it's normal in symmetrical type and smaller in asymmetrical type. And the neonatal cause, the symmetrical Iugr is complicated with poor prognosis. Asymmetrical type is usually uncomplicated and having good prognosis. Next, Ponderal Index. The Ponderal Index is used to determine those infants whose soft tissue mass is below normal for their stage of skeletal development. It means birth weight into 100 divided by crown heel length. So the typical values are 20 to 25, and those who have a ponderal index below the 10th percentile can be classified as small for gestational age. And the ponderal index is normal in symmetric IUGR and it's low in asymmetrical IUGR. This content was taken from SlideShare. Next, in the picture you can see the first picture, it is normal, means the fetus is having normal head as well as normal abdomen. So the fetus is having normal growth. And in the second picture, it is symmetrical because small head as well as small abdomen. So it's a symmetric type. And in the last picture, the baby is having normal head but small abdomen. So it's a asymmetrical type. Next, according to newer classification, so the first is normal small fetus. So in this case, they have no structural abnormalities and they have normal umbilical artery and liquor, but the weight is less, and they are not at risk and do not need any special care. Next, second, abnormal small fetus. They have chromosomal anomalies and structural malformation. They are lost cases and deserve termination as nothing can be done. So since the fetus is having chromosomal abnormalities, in this its termination of pregnancy is required. Next is growth restricted fetus. So it is due to impaired placental function. So if we are finding it early and appropriate treatment is given on time, or in some cases termination of pregnancy is required. So these were the management. So it was also taken in SlideShare. And next, moving on to etiology, maternal causes, then fetal causes, placental causes, and unknown. So first, moving on to maternal causes. So short stature women and the maternal genetic history and racial background. Then if the antenatal mothers are not taking proper nutrition during their pregnancy, and if the pregnant mothers are affected with anemia, hypertension, heart diseases, chronic renal disease and collagen vascular diseases, and if the pregnant mothers are exposed to toxins, alcohol, smoking, heroin and drugs, so it will lead to intrauterine growth retardation. And next is fetal causes. So mainly the fetal causes means if the baby is not getting adequate nutrients from the mother, or if any structural deformity or chromosomal abnormality, or if the mother is infected with torch infection, that is T for toxoplasmosis, O for other infections such as measles, mumps, etc. Next, R stands for rubella infection, then C for cytomegalovirus infection, H for herpes simplex virus infection. And if the mother is exposed to these infection, means definitely there may be IUGR. Next, multiple pregnancy. So multiple pregnancy, here the baby needs to share the nutrients. So in these cases, the baby will be having low birth weight or IUGR. Next, placental causes. So first is placenta previa. Here the placenta is present near the cervix. Okay, so what happened? Proper nutrients is not reaching the placenta. So if the placenta is not having any nutrients, then the baby won't get the nutrients. Okay, so it is the first reason. Next, second is abruptio placenta. Abruptio placenta means it's nothing but detachment of placenta. Here the maternal surface is not attached to the placenta. So what happened? The nutrients are not reached. Next, circumvallate placenta. Here the placenta is covered inside the maternal surface. So proper nutrients won't reach it. And next is infarction. Due to improper blood supply to the placenta, the cells will get damaged. Next is mosaicism. It's nothing but due to chromosomal deformity, the placenta's function is impaired. So here we can see the pictures. First is placenta previa. So here you can differentiate normal placenta and placenta previa. In normal placenta, the upside you can see the placenta. But in placenta previa, it's present downside. Okay. Next is abruptio placenta. In normal, it is attached to the maternal surface, but in detached placenta, here it is separated. Okay. Next is circumvallate placenta. You can see the first stage, it's normal. That is, it is properly placed on the chorion layer. And in second peak, slightly it is emerged. That is circummarginate, and in circumvallate fully it is inside. Okay, so the basal plate and the chorionic plate is not getting properly for the placenta. Next, mosaicism. It's due to like chromosomal deformity. The baby won't get adequate nutrients, so intrauterine death will happen in this condition. Next is unknown causes. About 40% of cases of IUGR is unknown. Next, pathophysiology. Due to etiological factors, the placental function is impaired. Okay, so due to that, what happened? Abnormal nutrient transfer is occurring. So the fetal response to abnormal or depleted nutrition supply occurs. So finally it ends in IUGR. Next, the basic pathology is due to reduced availability of nutrients in the mother, which reduce transfer by the placenta to the fetus. And it may also due to reduced utilization by the fetus. Next, the brain cell size. Asymmetric as well as cell number symmetric or reduced. It means in the asymmetrical type, the brain cell size is reduced, and in symmetric type, the cell number, the count is reduced. Next is liver glycogen content is reduced. Next, fetus is risk for intrauterine hypoxia and acidosis, which is severe, may lead to intrauterine death. Next, clinical features. Birth weight is about 600 gram. Here, the baby won't get, or the fetus won't get adequate weight gain. So, the birth weight is about 600 gram, and the length of the baby remains same. So, it is unaffected, and the head circumference is larger than the abdominal circumference in asymmetrical variety, and dry and wrinkled skin. That means it looks like old man look. Next, scaphoid abdomen, meconium stained vernix gaseosa, then thin umbilical cord, and as I have told already, the baby, all features of the baby will be giving old man look. Next, plantar creases are well developed, and the baby is alert, active, and have normal cry, and the eyes will be open. Reflexes are normal, even the baby will be having mororeflex. In this pic, you can see the weight deficit, then large head circumference, then old man look, cartilaginous ridges on pinna, dry wrinkled skin. Ear length remains unaffected, then eyes are open, well defined creases, normal reflexes, then the baby is alert and active, normal cry, thin umbilical cord. Next, scaphoid abdomen. Next, moving on to diagnostic evaluation. Monitor fundal height, liquor volume and fetal mass. Next, assess the symphysis fetal height, and if there is a lag of 4 cm or more, then it suggests Iugr. Then the mother won't get weight gain. Next, abdominal girth will be reduced while comparing to other pregnant mothers. Next, biophysical, head circumference and abdominal circumference should be monitored. Femur length is monitored, then amniotic fluid volume is assessed. Next, ultrasound Doppler parameters. So these ultrasound Doppler helps to assess the placental functions, then the blood supply to the placenta, then if there is any fetal wasting, how much degree of fetal wasting is there. So these things we can find by ultrasound Doppler. Next, biochemical markers. Here, elevated maternal serum alpha fetoprotein level, then elevated human chorionic gonadotrophin levels. Next, complications. Iugr will face number of consequences. So the complications are chronic fetal distress, fetal death, hypoxia, acidosis, respiratory distress syndrome, asphyxia, then meconium aspiration syndrome, intraventricular hemorrhage, then increased perinatal mortality and morbidity, pulmonary hemorrhage, then electrolyte abnormalities, DIC, that is disseminated intravascular coagulation disorder or coagulopathy. Next, retarded neurological and intellectual development, congenital abnormality and chromosomal defect. Next, management of mother with Iugr. So first is general things, complete bed rest, then 300 extra kilocalories should be given per day. Avoid smoking and alcoholism. Then 50 mg aspirin is helpful for mothers with hemolytic disease, hypertension and eclampsia. And antipartum evaluation should be done. Why means if there is bleeding during the antepartum period, that is during the pregnancy period, if any complications occurs means it will be assessed immediately. So for identifying it early, it should be done. That is biparatal diameter, head circumference, abdominal circumference and amniotic fluid index. Amniotic fluid index means the amount of amniotic fluid present in the amnion. Okay. So these things should be assessed by an interval of 3 to 4 weeks regularly. Next, fetal well-being is assessed by kick chart. Kick chart means the movements. They will be giving a chart and the mother has to mention how many times the baby is making movements inside the womb. Next, NST. It is non-stress test. This is also, it's like an procedure where the complete fetal well-being is monitored. Next, Doppler ultrasound parameters should be studied. Next, timing of delivery. So if the baby or the gestational week is 37 weeks, immediately we can go for delivery. And if it is less than 37 weeks means maximum we can wait up to 37 weeks. Then fetal lung maturity is achieved by beta-methasone therapy. Next, optimal management at birth. So we have to maintain the baby's temperature by drying and wrapping the baby, increase the environmental temperature, then covering the baby's head with a knitted cap, then skin to skin contact with the mother, and cover the baby and mother with blankets. And if we are delaying the first bath, it will be helpful for the baby because due to prematurity there may be difficulty to maintain a thermoregulation process in the baby. So to prevent that, we can provide warm room, and the bath can be delayed. Next, vitamin K 0.5 mg IM is administered. Then if warning signs are present, we can shift the baby to NICU. Next, monitor the baby for vital signs, activity and behavior, color, then tissue perfusion, fluid electrolyte and ABG analysis. Next, tolerance of feeds, look for respiratory distress syndrome, apneic attack, sepsis, patent ductus arteriosus and intraventricular hemorrhage. Next, feeding support. So if the baby is not having sucking reflex, means we can provide express breast milk, and the baby needs 120 to 130 kilocalories per day, and breast milk should be initiated as early as possible, and 20 to 30 gram per day weight gain should be there. So we have to concentrate that. Next, infection prevention. So already the immune system will be weak for the babies, but if it is IUGR, again it is complicated. So 5 C's should be followed, that is clean hands, clean cord clamping, clean surface, clean procedures. So strict aseptic techniques should be followed while providing care to the baby. Even though it is procedures or anything, whatever the nurse is doing for the procedure, she should be very conscious about it. Next, KMC. The skin to skin contact with her mother or any of the family members we can initiate, and it will be providing stable warmth and encourage frequent and exclusive breastfeeding. Next, neonatal resuscitation. In case of emergency neonatal resuscitation, that warm neonatal resuscitation should be given, and keep ready the bag and mask or mouth to mask or ET tube intubation. So which is preferred by the physician, that we have to kept everything in a well set. Okay, so that during the procedures it will be comfortable. So these are about IUGR. I hope you all understood, and if you have doubts, you can put your questions in your comment section. And I have referred textbooks like Miles, then pediatric textbooks, Wong's, then I have referred net reference also. So I hope it's useful for you. So hope you enjoyed it, and thank you for watching. And if you didn't subscribe to my channel till now, don't forget to subscribe. Thank you.